So today I'll be talking about the abnormal right ventricle, and that really consists of three major defects. We'll talk first about the anatomy, physiology, presentation, and outcomes of tricuspid atresia and pulmonary atresia with intact septum. And I think you'll learn that it's not just a small right ventricle. And then I'll spend the majority of the time on Ebstein's anomaly of the tricuspid valve, and that's not just a leaky tricuspid valve. So the basis of fetal right heart obstruction really is either at the tricuspid valve, in which case you have tricuspid atresia, or at the pulmonary valve, in that case you have pulmonary atresia with intact septum. Necessary for fetal survival in both of these defects is that the patent foramen ovale be of adequate size, because if there's obstruction to right outflow, everything has to go from the right side to the left side. The second thing is there has to be a patent ductus arteriosus to supply pulmonary blood flow, and the left ventricular function needs to be normal in order to support the abnormal right ventricle. This significant obstruction to RV inflow will alter the filling patterns and systemic venous return patterns, so you have to be very sure when you look at these patterns that you understand that the fetus is not in, quote, heart failure or soon to check out, but this is just a consequence of the anatomical aberration in these babies. There's the PFO and there's the PDA. So the pathognomonic finding in tricuspid atresia is that there's no right atrium and right ventricular connection. The valve is atretic. The majority of patients have a muscular VSD. And this VSD is very important because the larger the size of the VSD, the larger will be the size of the right ventricle, and the larger will be the size of the great artery coming from that right ventricle. And as we know, you can either have VA concordance, that is, from the right ventricle comes the pulmonary artery, and that is the most common form of great artery arrangement in tricuspid atresia. About 12 to 25% will have VA discordance, and that's detransposition of the great vessels. So you'll have the aorta coming from the hypoplastic right ventricle, and the remainder, which are very few, will have a common arterial trunk or an AP window, and those are very unusual. Tricuspid atresia is reported in about 4% of prenatally diagnosed cardiac defects. It has an incidence of 1 in 25,000 births. Chromosome anomalies are rare but do occur, and extracardiac anomalies are a little more common but are also fairly unusual. Interestingly, when you have VA concordance and tricuspid atresia, you have a 5-fold increased risk of fetal growth restriction, and that's very important, obviously, when you're deciding when to deliver these babies. So when you assess a fetus with tricuspid atresia, you have to look at the PFO, because some of these babies will have restrictive PFOs. This is a nice sweep here showing from the 4-chamber view the large left ventricle, the smaller right ventricle, the atretic tricuspid valve, the normally related great vessels. Here's the PA coming from that small right ventricle, and the VSD here. And you see, because this is such a large VSD, although the ventricle is small, the pulmonary artery is not that hypoplastic. And as we said, the VSD determines the size of that great vessel. You look at the great vessel anatomy and also the flow in the ductus venosus. Now, this is the most normal-looking ductus venosus flow I could find, but when you have tricuspid atresia, because every time there is a heartbeat, there is backflow into the ductus venosus, you can first have a low, an A wave that's very close to baseline, and you can even have an A wave during atrial contraction that's above baseline or going the opposite direction. Again, if you were using the cardiovascular profile score, you would worry that this baby was in distress, but again, it's just the physiology of tricuspid atresia. So there hasn't been a large study done in fetal tricuspid atresia, so if anybody's looking for a good research project to do, a nice multi-center study of tricuspid atresia would be good. One from 2010 from the European literature, and the other from 2007. And you can see they're both single-center studies. They both have a fair amount of patients. What's similar in both of them is the voluntary interruption of pregnancy is about 25 to 30%. The rate of fetal demise is pretty close, 3.7 to 4.5. But the populations are different because in the European study, all 25 had a neonatal procedure, so most of them did. But in the Wald study, all of them had a neonatal procedure. So these are generally the more serious patients. Turning now to pulmonary atresia and intact ventricular septum, and we'll talk about both tricuspid atresia and pulmonary atresia in a little more detail this afternoon. Pulmonary atresia and intact ventricular septum is, even though it's one of the so-called hypoplastic right heart defects, it's completely different than tricuspid atresia in anatomy, physiology, and outcomes. And that has to do with the fact that there is a small tricuspid valve, but the real issue is that there's no antegrade flow across the pulmonary artery. So that it's not that there isn't a pulmonary artery, it's there's no antegrade flow. So what happens to this right ventricle is it develops a very, very high pressure. It becomes thickened and hypertrophied. Pulmonary atresia and intact septum is rare, much more rare than tricuspid atresia. Only 1 to 5% of all congenital heart diseases. There's a high termination rate, probably because of the coronary anomalies that can accompany this. Reoccurrence is uncommon. It's much more rarely associated with chromosome abnormalities and non-cardiac defects. And the prenatal diagnosis rate many years ago was pretty low, but I think it's much higher right now. You almost always, because you never say never, right? You almost always will have normally related great vessels, and the coronary arteries are the big issue. So here's a nice picture of a patient with pulmonary atresia, intact ventricular septum. You see the difference right away in this right ventricle, how hypertrophied and dysfunctional it is compared to the tricuspid atresia ventricle. You see there's no VSD, and there is a small tricuspid valve, but it's very hypoplastic. Just like in tricuspid atresia, it's important to look at the size of the patent foramen ovale and the tricuspid valve size and the Z-score. Now, looking at the pulmonary arteries, you can see here that they're fairly good size, but there is pulmonary atresia. You can't really see a right ventricle here. This is another view of the same patient, again with the small right ventricle up here. You can start to see the pulmonary artery and the retrograde flow. And then you can also start to see this structure here, which is an abnormal coronary artery, an abnormal fistula. And from this short axis view, you can see the whole left coronary system here, the left main coronary artery coming from the correct sinus here. You should never see coronary arteries that large and that prominent unless you're dealing with heart sparing, which was not occurring in this fetus. So very important to diagnose those coronary artery abnormalities, as Tracy showed us. Turn your scale down, turn your wall filter down, and you should be able to see them. And they're important because they do change the prognosis completely of pulmonary atresia and intact septum. So the prognosticators and outcome in pulmonary atresia and intact septum have to do with the Z-score of the tricuspid valve. The lower the Z-score, the worse the outcome. Also, it has to do with the tricuspid valve mitral valve ratio and the length ratio, which you can calculate. If you look at the Dopplers, if you have moderate or severe tricuspid insufficiency, that is a poor prognostic feature, as is the coronary artery connections in this disease. Interestingly, a more recent paper from 2019 showed that not only is the right ventricular global longitudinal strain abnormal, as you can see in pulmonary atresia patients down here by the triangles versus controls, which is seen by the circle here, but also the left ventricular global longitudinal strain is also reduced. This really speaks to the interventricular dependence that occurs in so many of our single ventricle type diseases. One ventricle is affected, but the other ventricle is not normal either. It's even worse if you look at pulmonary atresia and attack septum with right ventricular dependent coronary artery circulation, those abnormal coronaries. As you can see here, the global longitudinal strain in the left ventricle is worse, and in the right ventricle as well. So again, these babies, even during fetal life, have a lot going against them. So I'm going to spend the rest of the time on Ebstein's anomaly and tricuspid valve dysplasia, because this is an area where we now have some hope for these babies, and it's a pretty exciting time to be in fetal cardiology because of that. So two different things. Tricuspid dysplasia occurs, as you see in this picture, when there is normal insertion of all three of the tricuspid valve leaflets. So here's the enlarged right atrium, here's the right ventricle, and you see that this septal leaflet of the tricuspid valve, although it's thickened and redundant, it does insert in the normal portion just as it should, and it's right across from the insertion of the mitral valve here. So that's tricuspid valve dysplasia. You can see the septal leaflet doesn't move very well. You can see that there's non-coaptation, that is, the valve leaflets don't come together like they should, and that is the etiology of the tricuspid valve dysplasia. This is a fetus with terrible tricuspid insufficiency. You see the very enlarged right atrium, which goes all the way back here, and you see the color originating from the failure of coaptation, and it really is at the same level and just across from the mitral valve. So this would be tricuspid valve dysplasia with color. On the other hand, Ebstein's anomaly of the tricuspid valve has a very abnormally displaced septal leaflet. It's often very sail-like, and it's absent, it's different, it's downwardly displaced from the septal ring. And the septal ring you can think of simply as just what's right across from the mitral valve. And you see here that the atrium goes all this way around here. You see this is the right ventricle, and note how thin-walled this ventricle is. It's about the same wall thickness as the atrium. So this has a very poor prognosis. This is another fetus with Ebstein's anomaly, where the valves coapt way in the septum here, and this septal leaflet is plastered down. You can't even really see it moving at all. So the fetal diagnosis is really made on ultrasound/fetal echo due to cardiac enlargement, predominantly from the right atrium. Again, here are the little tiny ventricles, and here's this gigantic right atrium. You can also see the variable degrees of tricuspid insufficiency. It's always there. Sometimes it's quite pronounced, other times it's not quite so bad. But one clue to know that you're dealing with something abnormal, if you see the patient really before the tricuspid insufficiency becomes severe, it's to look and see where it originates. And you see here how it originates much more deeply in the ventricle than it should. Then you can also have an arrhythmia, atrial ectopy, atrial flutter, or SVT. This is a fetus with Ebstein's anomaly. This is the AV valve ring, but this isn't where the valve is. You can see the valve is plastered way down here by the septum. And then another way to see, another way to notice Ebstein's anomaly is in the case where you have VA discordance and AV discordance. So this is anterior and rightward, and we see this is the left ventricle. This is the right ventricle here with the Ebstein's valve buried way deep in the ventricle here. So this is a patient with congenitally corrected transposition of the great vessels and Ebstein's anomaly. Another clue is to look at the interventricular septum. In both these cases, you can see that the septum is really kind of wonky. It's wobbling. It's totally abnormal movement. And that's due really to that septal leaflet, because that leaflet is right attached to the interventricular septum. And when you see that, it's going to be one of two things. The fetus either is going to have a bundle branch block, or there's going to be Ebstein's anomaly. And sometimes, interestingly, that's the first thing that people see. I've had referrals for funny looking and moving ventricular septums, interventricular septums. So it's interesting what people see. So there are associated lesions that go along with Ebstein's. A patent foramen or a secundum ASD is common. You can also see pulmonary atresia. Here we see a nice pulmonary valve right here, but you'll notice that there's really nothing going from the ventricle across that pulmonary valve. You can also have a VSD. Here we see a large muscular VSD here. There's a lot of color when you play it because the insufficiency jet comes right close to where that VSD is, but you can see it nicely. You can also have Wolff-Parkinson-White syndrome with Ebstein's anomaly, and this is shown on this ECG where you have a short PR interval and a slurred upstroke of the QRS, which is called a delta wave. You can also see it with ventricular non-compaction, LV non-compaction. I haven't ever seen this, so I've shown a picture. And then, as I showed you before, you can get it with congenitally corrected transposition of the great vessels. And just to review, the normal heart here and congenitally corrected transposition is when two wrongs make a right. So you have the blue blood after birth, the right atrial blood going into the left ventricle, the morphologic left ventricle, but then going to the pulmonary arteries to get oxygenated. So this is an example of Ebstein's anomaly and congenitally corrected transposition. You see the stomach here. This is posterior. And to the left, you see the Ebstein's valve here and the morphologic left ventricle anterior and to the right. Here you can see the severe tricuspid insufficiency coming from that leftward and posterior ventricle. And lastly, you can see the left ventricle here, which is giving rise to the branching vessel, which of course is the pulmonary arteries. But not every enlarged right atrium is caused by a tricuspid valve problem. This is a very unusual defect. It's from about 20 years ago, just because I haven't seen another one since that. But this is called idiopathic dilation of the right ventricle, of the right atrium. And it really is a diagnosis of exclusion. When you've excluded tricuspid valve dysplasia, when you've excluded Ebstein's anomaly, and everything looks fine except this right atrium is enlarged. And this is a primary problem of the right atrial wall. People worry about thrombosis. People worry about arrhythmias, and I think rightly so, but most people treat this with benign neglect or maybe a baby aspirin a day. So the checklist for tricuspid dysplasia, Ebstein's anomaly, includes looking at the situs, the AV and the VA concordance, and then the CT ratio, the morphology of the tricuspid valve, and you can get as fancy or as limited as you want. I'm sure Edgar's description of Ebstein's anomaly cover at least a page. Left ventricular function, the Z-scores of all the pertinent vessels and parts, the pulmonary valve, the main pulmonary artery, and the pulmonary artery branches, the location and the morphology of the ductus arteriosus. That ductus arteriosus usually comes from the underside of the aortic arch, and you can't see it as well from the usual views that we get in the normal situation. Yeah, one should also check for effusions and hydrops, as that is a very poor prognostic sign, and use your color and spectral Doppler for both the velocity and the direction of flow for the tricuspid insufficiency, the pulmonary pulmonary tree, the ductus arteriosus, the umbilical artery and vein, and the ductus venosus. So one of the interesting findings that really happened in the last century was this idea that there is this interdependence between the left and the right ventricles, and one of the features of Ebstein's babies who had poor outcomes was that they had abnormal left ventricular function. And one of the ways we can look at the left ventricular function is the TAE index, or the myocardial performance index, which looks at the relationship, and Julia discussed this morning, between the ejection times and the relaxation time and contraction times. And that can be measured from a simple mitral inflow and aortic outflow tract. What you'll also notice, interestingly, is that this AV interval is about 162 milliseconds. So that's not going to be first degree block. That's going to be really a feature of the dysfunction in this left ventricle. So Ebstein's is really important for a lot of reasons, but this is one of them, and this is from Edgar and his group. It's a 6-year retrospective case matched study of fetal demises among almost 2,000 patients with structural or functional cardiac defects. And you see that those with cardiomyopathy have about a 50% prevalence of IUFDs, but the Ebsteins are not far behind, about 27%. So it is a very severe and serious cardiac defect. So before the year 2000, we had a pretty good idea of the poor prognostic features, but they were in fact really kind of it was more a bird's eye view. And in the last 20 or 30 years, we've gotten much more specific about these. So CT ratio during fetal life of greater than 66%, right ventricular obstruction, and the LV compression, and poor left ventricular function. After birth, the neonatal poor prognostic features were a CT ratio of greater than 90% and right ventricular obstruction. Those were consistently the findings that marked a poor prognosis. I've listed some of the other ones too, which did not turn out to be really all that important. So there was a paper published in 2015, which was really and still is the largest multicenter study on Ebstein's anomaly in the fetus, and a lot of us contributed to it. It was 243 patients, which was really a fairly good cross-section. Of these 243, that you can see that the perinatal mortality, which is really the important part, was almost 50%, and that's if you include the terminations, the fetal demises, and the neonatal deaths. So even in the current era, Ebstein's anomaly is a serious congenital heart disease. So when they evaluated the patients in this cohort, they found some interesting features. First of all, that the amniocentesis was abnormal in about 20%, which is a little bit surprising because Ebstein's anomaly, I think, is not something that we who do clinical care really think of as having chromosome anomalies. Of the patients who had a level 2 ultrasound, surprisingly, not all of them were reported, only 186. An extracardiac anomaly was found in almost 30% of them. Again, kind of a surprise because at least I don't think of Ebstein's with extracardiac anomalies. The lung volumes, the fetal lung volumes, not surprisingly, were abnormal and small in 56% of patients. But the other kind of interesting thing is we talk a lot about the prognosis of Ebstein's as having difficulties with lung volumes, with oxygenation and such. But it's really been, I think, the experience that the lungs are really squashed. It's not that the lung volumes are small, and that once these babies start breathing, then the lung volumes increase, and they don't have a lot of respiratory issues. Surprising for me, because I love arrhythmias, only 6% of the patients had arrhythmias, and about 7% were treated for ventricular dysfunction. Now, these are the neonatal outcomes, which were divided really by weight. And the dark part here are those babies that were live born but died after birth. And the white part is those who were live born and survived. And you can see that when you're small, you're much more likely to die when you have Ebstein's anomaly of the tricuspid valve. And then they looked at and that was especially true if you were born prematurely. And as you got more mature, there was less risk of death. So prematurity is definitely a risk factor for a poor outcome. So looking at this study and then a follow-up study, which was published not too long ago, the factors associated with the perinatal mortality at the time of diagnosis, okay, so this is just the time it was diagnosed, using multivariate analysis were prematurity, so a gestational age less than 32 weeks, and the odds ratios are presented in the slide as well. A larger tricuspid valve annulus diameter, that is greater than 6 z-scores, and you remember because of all the insufficiency, the right atrium dilates, and then the tricuspid valve annulus dilates as well. The presence of pulmonary insufficiency or pulmonary regurgitation, and a pericardial effusion. Now, they also looked at late gestation factors associated with mortality, and these were patients who either progressed or presented later. And they found that if there was pulmonary regurgitation at any time during the course of the fetus's life, that was a poor prognostic sign, that babies or fetuses were likely to die much more commonly, really twice as much as if they didn't have pulmonary insufficiency. And a follow-up study done on this population showed that absent or reversed end-diastolic flow in the umbilical artery, which we all know is a very poor sign, and an umbilical vein velocity z-score of less than 1, so that means that there wasn't a nice S and a D wave, on fetal echo before birth at a median of 27.4 weeks. So the last echo before these babies were born was also a risk factor. So another question, which was also answered a little bit after the original article, was what happens to these babies? How do they progress, or do they progress? We know that so many fetal congenital heart defects are progressive, such as tetralogy and pulmonary atresia. Ebstein's is too. So they looked at 51 of the fetuses who presented very early, so before 24 weeks, and they compared that study done initially with a study that was done right before the baby was born. They defined a poor hemodynamic status as a CT ratio greater than 48%, LV dysfunction, pulmonary atresia and pulmonary regurgitation, and a tricuspid valve annulus diameter greater than 5.6. And what they found was in those fetuses who initially had no marker for poor hemodynamics, that is, none of these things up here, that only 14% continued to have no poor marker. So there was a lot of progression. Those who had antegrade pulmonary blood flow, 53% of them had it on the first echo, but only 35% had it on the last echo. So another progression. Of those patients who developed pulmonary insufficiency, 18% developed it that didn't have it on their first echo. And left ventricular dysfunction really increased the most. Again, it's that ventricular-ventricular interaction. The tricuspid annulus z-score increased and the CT ratio increased, which shouldn't come as a surprise to anyone who's taking care of these babies. So what is the pathophysiology of this? Why is this such a dreadful disease and just not insufficiency? So this is kind of a funny picture, and I'll guide you on it here. This is the large pleural effusion here. This is the pulmonary artery, pulmonary valve here, and the pulmonary arteries here. And then this is the right atrium here and the right ventricle. And you see a lot of things here besides the effusion, which is very obvious. But if you look very carefully at this pulmonary valve, you'll see it's really just kind of bobbing around. It's not really definitively opening and closing. And actually, if you look at this picture here, which the right ventricle is here, left ventricle is here. This is the pulmonary artery, and you can see there's really free pulmonary insufficiency. That is, pulmonary insufficiency during systole and diastole, which means the valve is just kind of held open like this, and there's really no antegrade blood flow. We also look at the umbilical vein and the umbilical artery, which are very abnormal. There's absent end diastolic flow. There's a little bit of notching in the umbilical vein. And a really important feature, which we hadn't talked about yet, is the velocity of this tricuspid insufficiency. Now, if you recall, the velocity of the tricuspid insufficiency is going to tell you about the pressure in the right ventricle, right? And the higher the pressure, to a certain extent, is a good thing, right? Because it means that the ventricle can generate a lot of pressure, that ventricle is healthy. If you think about patients, for example, with pulmonary stenosis and kind of a hypertrophied ventricle, those patients can often have tricuspid insufficiency velocities of 5 meters per second, which implies a pressure of 100 millimeters of mercury. So that's a healthy ventricle. These ventricles are generating pressures of about 3, which means it could only generate, that right ventricle can only generate 36 millimeters of mercury. And that's why that pulmonary valve doesn't open. That's why you have pulmonary atresia, because there's just not enough of a pressure head to open that pulmonary valve. And if that valve is kind of in a semi-closed position, then you're going to get the pulmonary insufficiency too. So what we most worry about in these babies is what we call a circular shunt. And this is just kind of a very detailed diagram showing really what happens with the circular shunt. And we start with the severe tricuspid insufficiency, which is present. That can cause a volume load, first of all, on the right ventricle. The right ventricle dilates and has a reduced contractile reserve and making it unable to generate pressure. So that's kind of one arm of what happens. Because there's a lack of antegrade pulmonary blood flow, right, because there's not enough pressure generated to force blood past that pulmonary valve, you need retrograde ductal flow. So flow goes from the aorta through the ductus into the pulmonary arteries, and that increased flow causes an increased right ventricular afterload and preload, again affecting the ability of the right ventricle to generate adequate pressure. The tricuspid regurgitation is going to favor a capacious venous circuit, right? If you have a leaky valve, when the ventricle pumps, it's going to be much called easier for that blood to go backwards into that very dilated right atrium because the pressure is lower than it is in that right ventricle. So it just becomes a very vicious cycle, and there's inadequate filling and decreased preload of the right ventricle. So again, we get the failure of the right ventricle to generate adequate pressure. And this lack of antegrade pulmonary blood flow, retrograde ductal flow, plus low RV pressure are precursors to the development of the pulmonary insufficiency, and that's the final insult that then completes the circular shunt. So basically, the effects of the circular shunt on the heart, especially the left ventricle, because your right ventricle we showed is already compromised, but what happens to the left ventricle? This circular shunt bypasses both the systemic and the pulmonary beds. There's systemic steal. There's a further volume load to the left ventricle as well as to the right ventricle, and the septum is displaced. And there's adverse interaction. Remember how I showed you that septum, that funny septal movement? That's what I was talking about. So there's ineffective volume loading, dysfunction of the LV, and it just goes on and on. So the question is there anything we can do about this? What we used to do is just deliver these babies after 32 weeks or even before, once they started getting hydropic. It was really our only option. And I still actually remember the conversation when we were talking about this. And it was Wayne Turetsky, who's a fetal cardiologist at Boston Children's, who I remember, he sat down, we were sitting around, and he pulled out a napkin, and he pulled out a pen, and he started drawing pictures of circular shunts. And he said, what do you think would happen if we cut out the ductus from this circular shunt? So what indeed would happen if you cut off that ductus? And how do we cut off a ductus in utero? Anybody who's taken care of a baby or a mother who's in premature labor, right? Or a mother who has too much amniotic fluid, what do you give them, right? The best drug we have, indomethacin, right? And what's one of the side effects of indomethacin? Ductal constriction. So, the proof of concept paper was published in 2021, NSAID therapy for fetal Ebstein's anomaly with circular shunts. So it was comprised of 15 pregnant subjects from 20.9 weeks to almost 35 weeks with fetal Ebstein's, pulmonary insufficiency, and so by definition, a circular shunt. So these ladies were given indomethacin. That they found fetal ductal constriction in 80% of the fetuses, and 1 to 6 days after treatment, the pulmonary insufficiency improved in all of them. What was the effect on the outcome of the babies? Well, the gestational age at the delivery of the patients who successfully had ductal constriction was 30.7 to 39 weeks versus 23.3 to 37.3 weeks, which was the gestational age of those who failed to constrict the ductus, where indomethacin failed to constrict the ductus. All of them were treated with indomethacin, and that was a statistically significant p-value. 11 out of the 12 who had successful ductal constriction were live-born versus 4 out of 9 who didn't have ductal constriction. Those babies were live-born. And again, a barely statistically significant result. Now, of course, there were side effects. And one of the big side effects, of course, is oligohydramnios. And that did happen in a fair proportion. So people now are saying, well, what if we give Tylenol, acetaminophen, that we know can constrict the ductus too, just not quite as well. So it's a work in progress, but at least the proof of concept has been proven. So what happens with these babies then if we can keep them going for a couple more weeks, keep them from not becoming hydropic? What happens after they're born and they're no longer under the care of the fetal cardiologist and the maternal fetal medicine doctor? Well, there's kind of two options. And the mistake that we made early on was thinking that we could kind of ignore this tricuspid valve. We could, put in a ductal stent, we could put in a shunt, but really what we were doing was just making the circular shunt worse. So we decided that a lot of these babies could be handled by a procedure called the Starnes procedure. And sometimes you did it right away. You usually did it right away. And sometimes these babies could go on to get a biventricular repair. And sometimes they needed a single ventricle pathway. And those patients usually had a very small functional RV, so very something that wasn't generating a lot of pressure. Poor tricuspid valve morphology, so the valve was difficult to work with and you couldn't really make it better. And the TR velocity was less than 3 meters per second. So again, that ventricle was not capable of ejecting a lot of blood. So if you had a hemodynamically unstable neonate with end organ dysfunction, but an adequate right ventricle, you still had to get them through the neonatal period. And that's why they did the Starnes procedure. And the Starnes procedure is shown in this top diagram here. And the idea is that they oversew the tricuspid valve so they can get it out of the way, but you still have to have a little egress for the blood in the right ventricle to get out, because otherwise it would just keep getting bigger and bigger. So that's the Starnes procedure, and they always leave the ASD. There's a modification where the patch is slightly different, and that's called the Sano modification. So it's described down here. The modified Starnes is a fenestrated patch, that means there's a little hole in it, of the tricuspid valve to allow RV decompression. They ligate the main pulmonary artery, especially if the valve is incompetent with the pulmonary insufficiency, and they do an atrial septectomy, put in a shunt, because if you're ligating the PA, you still have to have pulmonary blood flow, and sometimes they do an atrioplasty if that right ventricle is right atrium is really, really large, so the lungs can grow. Well, how does this work? This was a recent study looking at the single ventricle outcomes after neonatal palliation with the modified Starnes procedure, and the conclusion was that the long-term single ventricle outcome among neonatal survivors of the modified Starnes are excellent. There is a reliable remodeling of the excluded right ventricle and good function of the left ventricle. So at this point in 2023, we are giving indomethacin to these patients with circular shunts. We are doing the modified Starnes procedure. So I think that there is hope for this population, which before was pretty hopeless. So thank you so much for your attention.